Welcome to This Week in Health IT, where we discuss the news, information, and emerging thought with leaders from across the healthcare industry. This is episode number 30. Today, we take a look at 23andMe privacy scandal, and we check in on JPM, Berkshire, Amazon Health, which really cannot get a name soon enough, so we don't have to keep saying JPM, Berkshire, Amazon Health. This podcast is brought to you by Health Lyrics. Health systems are moving to the cloud to gain agility, efficiency, and new capabilities. Getting to the cloud and operating it represents new skills for the IT organization. Work with a trusted partner that has been moving health systems to the cloud since 2010. Visit healthlyrics.com to schedule your free consultation. My name is Bill Russell, recovering healthcare CIO, writer, and advisor with the previously mentioned Health Lyrics. Before I get to our guest, an update on our listener drive. Our sponsor has agreed to give $1,000 for every additional 100 subscribers to our iTunes, Google Play, and YouTube channels. We are just 30 subscribers short of raising $3,000 for Hope Builders, an organization that provides disadvantaged youth life skills and job training needed to achieve enduring personal and professional success. I've hired their graduates, and their stories are really inspiring. Join us by subscribing today to be a part of giving someone a second chance. Today, we're joined by one of those people whose articles I really enjoy reading, someone who has one of those bios, and we have several guests on this show that make me feel like such a slacker, and your bio is another one of those that just makes me feel like a slacker. Today, we're joined by Dr. Lee Milligan, CMIO for Asante Health System in Oregon. Good morning, Lee, and welcome to the show.
Morning, Bill. Very happy to be here. Thanks for having me.
Well, you know, your bio does make me laugh a little bit. It really is a blueprint for a type A personality. You know, you have 4 wonderful kids and a wife who's also works in the healthcare industry. You have, the usual credentials, graduated from University of Utah, George Washington University Med School, UCLA internship. You practiced medicine for 10 years. But then, you did that crazy stuff. Like you went back to school in 2010 to pursue a computer science degree. I mean, what precipitated you doing that? I mean, why? You're already a physician. Why go back for a computer science degree?
Yeah, I've had a lot of my friends ask me that same question. I think ideally it came down to, I started to see this real bad accident about to happen between this intersection of medicine and computers. And some of my friends at other institutions were on EHRs and were describing their really bad experience utilizing it. And so we were on paper at that time, and we were thinking about going to an EHR, and it just dawned on me that kind of getting my head around this space would really be advantageous, not just for myself, but for our institution.
Yeah, and so in 2011, you guys make that EHR leap. You become Epic Credential Trainer. You also become an Epic Physician Builder in basic orders and analytics. Was that really valuable? And is that a something that you really encourage your physicians to do at your health system?
I do. We have 11 physician builders here, and I feel like it's a critical element of getting the docs part of the conversation. I think it's hard for docs to really want to be part of that whole process if they feel like they don't really even understand the vernacular of what the IT folks are talking about. And in many ways, this program is a way to introduce them to those concepts. So I think for the system, it's a terrific advantage.
So, and this is where, I just feel like a slacker. So you have multiple board directorships, the health system, the physician partners, Propel Health, Oregon ACO, and I guess in your spare time, you're also a CMIO, or that's your primary job, right?
That's my primary job. Although
okay.
I will say that my areas of focus are on data analytics, data governance, this physician builder program, and most recently, our health information systems department now report to me. And we're in the process right now of unifying our ambulatory and our inpatient health information services.
Which is great. So that's what I'm looking forward to in the soundbite section. We're going to really go into informatics and what you guys are doing in that area. So you're also board certified in clinical informatics, which you say is the hardest board exam you've ever had to take. Is that really true?
Yeah, I mean, I think for everybody it's a bit different. It's been around for 5 years now. And like a lot of these new board certifications, they start out by grandfathering folks in if they've had enough experience. And then eventually you have to do an actual 2-year fellowship before you qualify to take the test. I was part of that first cohort who qualified to take the test without the fellowship, but the test itself was pretty dang hard. Studied pretty hard for it, but it was a really great learning experience. I have to say a lot of the stuff that I apply today I actually learned in the preparation for that board exam.
Wow. So, so one of the things we like to do is just ask our guests, what they're excited about, what they're working on today, and really, I'm just going to turn the floor over to you and talk about whatever has your interest right now.
Okay. There's a lot of things on the plate and a lot that hold my interest, but I would say in general, the theme of minimizing friction is top of the list. Right. And that could be patient friction. Near and dear to my heart is provider friction. And one of the ways that we're looking at doing that is really improving voice recognition. So, we've used voice recognition up till now, but we haven't really gone further than a kind of a superficial utilization of it. I would love to get to the space where eventually we're using voice recognition to do all of our navigation throughout the electronic health record. We could just simply say, pull up chart review, pull out all the CTs of the head in the last 3 years and list them for me, and then you can see them beautifully. I think we're on the cusp of getting there, but not quite. But that's really what gets me motivated right now is that voice recognition and NLP world that we're heading into. The other piece from the patient perspective is just, simple stuff like optimizing the patient portal. Simple concept, but really, if you get that thing right, it impacts everything else. If patients can see their lab results, their chart notes, then they're not actually calling our call center. And so that volume comes down. So it has a tremendous enterprise-wide effect if we get that piece right.
Yeah, we don't talk about vendors that much here, but I mean, when you talk about voice recognition and voice navigation, are you talking about like just the basic nuance kind of stuff, the nuance products? Or are you talking a suite of products that you're looking at right now?
So both M-Modal and Nuance are in this space. They're kind of the Microsoft and Apple kind of going at it, which I think is good. I think it's healthy for the industry to have those two kind of going at it. We happen to use Nuance, and we're looking at their cloud-based program now, which, the cloud-based voice recognition has a lot of advantages moving forward, including the fact that from the provider perspective, you don't have to train it. So normally when you have a network edition, the doc has to sit there for 15 minutes and train this thing to get it up and running. And frequently the file corrupts. So now picture this, it's 2 a.m, you're seeing patients in the ER, you're flying through patients, the waiting room's packed, you're about to dictate, your thoughts on a patient and the thing corrupts.
Right. Yeah. And so we've been doing charting and notes for a while within Nuance. I think we were doing that probably 5 or 6 years ago, maybe 7 years ago. But now when we get to navigation, I mean, it really becomes more of a Star Trek kind of thing where you just, hey, computer, tell me what the vitals are for this patient. Hey, computer, that kind of stuff. And yeah.
And I think that's a good point. And I think, that's where we get over that hump of us working for the computer versus the computer working for us. Yeah. I think the first couple of years we were on the EHR, really, we felt like we were all data entry monkeys putting stuff into the computer, and it wasn't really doing much for us. What you just described, in my mind, is really the computer flipping that and now working for us.
Yeah, and it's those movies that gave us the picture, and you have your Luke Skywalker Hope poster there behind you, telling everyone.
My nerdiness is coming out.
Yeah, exactly. And my Star Trek reference. So, all right, so let's jump into the show. So what we do is in the news and sound bites. In the news, we each pick a story to discuss. And sound bites, I ask you a series of questions, and we'll go into analytics this week. So I'll kick us off. 23andMe. So story is 23andMe is sharing its 5 million client genetic data with drug giant GlaxoSmithKline. And this is from Live Science. I'll read some of this. Actually, I read a bunch of this because it's really fascinating. So 23andMe, GlaxoSmithKline have signed an agreement. They're sharing the DNA data. During a 4-year collaboration, the London giant Glaxo and 23andMe will get access to 23andMe's genetic database to zero in on possible targets for treatments for human disease. The goal of the collaboration is to gather insights and discover novel drug targets driving disease progression and develop therapies, says a spokesman for GlaxoSmithKline. And it's not yet clear what conditions, but here's an example that they give. And it's the gene LRRK2, which is linked to some cases of Parkinson's disease. Only about 10,000 of 1 million Americans with Parkinson's disease have this disease because of that gene. So GlaxoSmithKline has to test about 100 Parkinson's patients to find just one potential candidate. However, 23andMe has already provided 250 Parkinson's patients who have agreed to be recontacted for Glaxo's clinical trials, which may help the pharmaceutical company develop a drug much faster. However, not everybody's really excited about this. One quote, if a person's DNA is used in research, that person should be compensated, says Peter Pitts, Center for Medicine in Public Interest, and goes on to say, if they opt in, they should be refunded the cost of the test. In addition, even though 23andMe gets consent of its customers to use their genetic data, it's unlikely that most people are aware of this. And Yale Law School Information Society Project fellow Tiffany C. Lee says the problem with a lot of these T's and C's and privacy policies is that no one really reads them, which is probably true. We've all clicked through those pretty quickly. But it's important to note that the new collaboration isn't the first time 23andMe's vast pool of genetic data has been mined by scientists. San Francisco startup has already published more than 100 scientific papers. And it goes on to say 23andMe has more than 5 million customers who have had their DNA analyzed for ancestral data. People who would like to close their account, they actually can do that. However, they go on to say that any research that has been done to date will not be withdrawn, but they will throw away your samples and those kind of things and not use them moving forward. So social media runs the gamut on this. Here's some quotes. This is an outrage. Another quote, the whole enterprise is a fraud. They're selling to naive people useless tests under false pretense. Then there's the cynics who are responding to them, say, you didn't think their whole business model depended on $99 test kits, did you? And then there's even some support. It doesn't bother me in the least. The quote, it doesn't bother me in the least if they are able to help just one person carry on. So, all right, that's a ton of data. I just wanted to set that up. So should we be surprised or even outraged that our genetic data is being sold?
I think this is the question of the 21st century. I think we're going to be having our, I'll call it biologic information, captured, stored, and sold in a variety of formats, whether it's facial recognition or whether it's DNA. I think it's going to be something that will be, from a technology perspective, ahead of the law. I do think the legal aspect is an important one, and I think the legal folks need to move a bit faster in terms of keeping up with technology. But right now, it's a legal thing to do. If that really long thing people are signing, we all do it, as you said. But I think from a legal perspective, it is legal. Is it ethical? I think there's a lot of debates on both sides of that. I think the business aspect that people have called out is interesting. I wonder if moving forward, if they could gather even more information from the individuals and then pay them for that more information. So for example, everything is sent over de-identified, but what if people were willing to be identified? And then on top of that, they were willing to provide additional context to their clinical scenarios throughout their lives. So they could, I've been a smoker for 30 years, or, I have a family history of X, or I've personally had Y. That would be really helpful in terms of connecting the dots between the genes themselves and the actual phenotype, the outcome of what occurs. So that's just one thing to consider.
Yeah, no, that's interesting. And I think that's, I always come down on the side of the patient on this. So I look at it, and somebody gave me this analogy, and I forget who it is. I wish I could give them credit, but we're almost like digital serfs working the land for the lords of the internet. So we generate all sorts of data on ourselves, and then we allow them to sell it. And we've done this on another show. We talked about how the medical record and parts of the medical record are being sold. And that's now become a $30-40 billion industry. But none of that value accrues back to the patient. And that's, that's where I think we're a little out of kilter here. I think people are upset finding out that their data is being sold, and none of the value accrues to them. None of the financial value accrues to them, but none of the intrinsic value of knowing I'm helping in this study. So I would really like to see Well, let's go to an area where we live. So at the health system level, so the medical record. We've talked to a lot of people about, should the medical record be owned by the patient? And there's a general consensus that it should, but it's not really. And I think we'll know it is at the point where the patient has access to the entire medical record, every note, every piece of information that's on it. They become the carrier of it, not the HIE. So they're the ones who are going from physician to physician or system to system, and they're granting access to those systems. They're essentially going, hey, you're gonna care for me for the next year. I'm going to give you access to my medical record for the next year so that you can be a part of it. And they share it. Your system takes it in. You care for them for the year and add to that medical record, but it all goes back to them. And then they control it. They sit there and go, hey, you know what? I want to participate in this cancer study. And they go, I'll share my information over there. I get, $25 for that. And I'll share it with this heart study. That's another $25. And people can then start to feel good about contributing back to society, but also getting financially compensated. Do you think a model like that is possible, or how far away do you think a model like that would be?
I think the devil's in the details on something like that. Philosophically, I agree with it. And I love the idea of the patient really owning their record, not just so from the ownership perspective, but what it would signal to me is they're more engaged in exactly what's happening. And one of the big challenges we have in medicine, of course, is having doctors communicate with doctors effectively. And if the patient's more engaged in that process, I think they can encourage that communication. But the devil is in the details. So let's say the patient owns the record and has access to the record and can even edit the record.
Ooh, yeah, that becomes a challenge.
Yeah, and if you look at the major vendors right now, they're providing that capacity within the patient portals. So then what do you do with that information? That I think one of the things that docs count on as they interact with a patient's chart is that the other person writing it, that person is accountable for what they wrote 100%. And I can hold them accountable. And I actually know that guy because we go to lunch together or whatever. And so you have this kind of a relationship. If the patient can edit the record, I think the level of confidence in what's in there will be changed.
Right, but there's a way to handle that. I think the simple way to handle that is to document the source of the data, right? So, and we had to do this within our systems, especially our HIE and other things, because to be honest, I mean, doctors don't trust other doctors in some cases. So they wanted to know what doctor put that information in, and then they would look at it and go, I don't trust his data anyway. And so they can then make their determination based on that. But we could do that with patient data as well, because we did that with demographic data.
Yeah.
If they say, hey, I have a new address, we say, patient entered data, new address, which triggered in our processes, what it triggered was a verification phone call to that person to say, hey, we noticed you updated this information. Is it accurate? They say yes. Once it gets verified, then it becomes part of our record system of record.
Yeah, that makes perfect sense. And the other way to do it is to have the patient be able to add but not delete. So if you can add and you know who it's coming from, you can see what that is, but you can't delete something that was there before. That might help as well.
Yeah, it's interesting. One of the arguments that has been given to me is that we're really trying to protect people from themselves, right? So you're a physician, so you're going to understand 99% of what's in your medical record. I'm only going to understand 60% because I'm in the industry, but there's some people who are only going to understand 30 or 20% of what's in their medical record, and they could make poor decisions based on data that they don't understand. What's your response to that? How do you address that? And is that just part of the we give people control of cars, we let them become parents, we let them, there's a whole bunch of things that we give people control of because that's the right thing to do. And then it's really up to them to make good decisions from it.
I think there are things we can do to smooth that out. So for example, have you heard of the Open Notes collaboration?
Yep, absolutely.
So, Open Notes is a terrific philosophy, and it's been, I'd say 6-7 years now, it's been kind of rolling out across the country. Some hospital systems have been more amenable to adopting it than others. We're kind of working our way towards it right now. But in general, it allows the patient to immediately see what the note said. And, the docs who are participating in that, they have to change their vernacular. They used to, I would say I got a 25-year-old, white male SOB, and SOB in my world is shortness of breath.
Right.
But if I'm not medical and I read that, I'm going to be pretty upset. So the docs need to adjust their vernacular, recognizing the patients are going to read it for the first time. But how amazing would it be for the patient to be able to look at their note and clearly see the plan for each issue they're dealing with and have that as a record? That's huge.
Yeah. And if I read that, white male SOB, I would say, how does this physician know me so well? Anyway,
Right.
so let's go to the next story. I'll kick it to you. You could set it up for us.
Okay, so I wanted to talk a little bit about the Berkshire Hathaway, JP Morgan Chase, Amazon approach. And as you have stated already, I would love to have a specific short name for this entity that they're working on. But essentially, they decided to get together and work on healthcare as it relates to their employed individuals. And so that's about 1.1 million individuals.
Right.
But what I wanted to point out was after they selected Atul Gawande to be their CEO and to kind of lead this area, that really gave me a lot more confidence in what they were doing. Not only because Gawande is highly respected, legitimate, authentic, comes up with long-term practical solutions to complex issues, but because we have a point of responsibility and accountability in their process. Before we had three guys kind of at the helm, and I think about it like when I send an email to three people and I say, can somebody take care of this for me? Chances are nothing happens.
Right.
But if I ask one person to do it and maybe CC the other two, it can actually have a chance of happening. So I thought that was a great step forward when that happened. But most recently, listening to Jamie Dimon talk about their process has also given me a little more confidence in the direction they're going. He referenced Bezos as it relates to Amazon and how he spent 10 years focusing on books, recognizing that it was going to be the everything store at some point, but really getting books right. And that's the model that they want to use moving forward, which I respect because this topic is hard.
Yep.
And there's a lot of complexity to it. Listening to him talk, he's already getting the vernacular down as it relates to this issue they're trying to solve. So he's talking about everything from drug prices to supply chain to irrational variance in the way we deliver care. These are terms that people don't usually use unless they've really been involved in these discussions. So that kind of got me a little more excited about the process they're going through.
Yep. I think the expectations are so high for this thing that the leaders are walking it back a little bit just to say, hey, we're gonna take baby steps here. We're not gonna solve healthcare, if you will, overnight. We're gonna address this. This is the second week in a row I'm going to be giving this gentleman a little bit of credit. And Dale Sanders, president of Technology for Health Catalyst, posted a thing about 10 hours ago on LinkedIn, and it's a picture of Jeff Immelt, and it says GE was spending $3 billion a year on healthcare costs, more than their annual revenue of their healthcare line of business, and that gives you some idea of the challenge and the problem and why these employers have decided to step in. But here's what I'd like to do with you this morning. There's another article on Apple. Right. So we have competing, models. So you have JPM, Berkshire, Amazon, you have Apple. Intel's had a model for quite a number of years. And there's other employers. I'm sure Nike has one probably up in Oregon and others. But I'd like to talk through the Apple one, because there hasn't been a lot written about it. And 2 days ago, there was an article on it. So Apple's first hires for its health clinics show how it's thinking different about healthcare. Okay, so Apple's wellness clinic, AC Wellness, has made quick work of hiring more than 40 people to provide concierge health and wellness services at its Bay Area for its Bay Area employees, according to a LinkedIn search. Apple is far from the only employer starting it. We've talked about that. But Apple's approach stands out in its focus on care as not just treating disease. On its website, AC Wellness details how it's looking for candidates to join the group who have experience in patient experience and a passion for wellness and population health. And so here's a couple of examples. Most of the team hired so far aren't doctors. In fact, the hires skew towards wellness professionals, nutritionists, exercise specialists, and nurse practitioners. A lot of the hires have background in alternative or functional medicine, and there's even a wellness lead. Jennifer Gibson, a former head of coaching at Vita Health, health tech startup. Gibson, according to her profile, is passionate about things like nutrition, stress management, smoking cessation, which aren't always offered as at primary care practices. The company has also brought in at least a half dozen care navigators who don't have medical degrees, but do have a background in directing patients to the most appropriate care. In some cases, that might involve follow-up conversations with a specialist or lifestyle change that might alleviate the problem on its own, and that could help reduce costs. The MDs it has hired, like former Stanford community physician Darren Phelan, emphasize on their LinkedIn profiles that their vision for AC Wellness involves putting care back into healthcare. Another former crossover doctor has a distinctive focus on sleep, which is uncommon in primary care clinics. And, many of the new hires have, worked in healthcare startups and other things. And, so as you look at this, they're really moving away from this. Their mindset isn't fee for service like a traditional health system. Their mindset is, how do we keep these people healthy? And we all know that this is the future of medicine. We've known that if we can keep people out of the hospital, that's a much better model. So I guess my question on this, as we sort of compare, maybe not compare and contrast these two models, let's compare and contrast these two models with what's going on in the traditional health system. How are the emergence of these models covering millions of patients going to change traditional healthcare organizations? And what should our traditional healthcare organizations' response be to these kinds of programs, do you think?
So, historically, we've had just an awful model. Our awful model consisted of, patients come into the hospital for appendicitis, and they get a Foley catheter placed, which gives them an infection. We then get to diagnose the infection and get paid for that. Then we get to treat them for it. And if they get really sick, they go to the ICU and get paid for that as well. All stuff we've caused.
Right.
And so I think everybody's in agreement that model has to go away. I think that, again, the devil's in the details on how it's executed. If you think about these primary care setups that you're describing, it has to be under the umbrella of a financial model that pencils out. Because there's all kinds of great things we can do, some of which have been proven, others of which have not been proven. There's a lot of kind of back and forth literature on care management, for example.
Right.
And I would say that in order for it to be truly successful, it's got to first start out under a financial model that rewards doing good. In other words, if I have finite resources and I can work on 10 things, I need to pick the 10 things that I know will not only help the patient, but also will pencil out at the end so that this whole process can move forward. So in our system, for example, as we think through how to implement population health, we're carefully identifying areas of opportunity that put us in that frame of reference, where we're doing good for the patient, perhaps decreasing imaging, for example, low back imaging, MRI, for example. But again, you want to do that under a model where it's going to reward that goodness. And I think the danger on a lot of these systems that I'm seeing is that they have a lot of great ideas going in, but at the end of the day, it's got to funnel into making it financially move forward.
And so, going back to that GE example, it pencils out for employers because they're spending $3 billion on healthcare costs.
Well, it only pencils out if all the things they're doing actually do good.
Yeah.
And I think there's a lot of great ideas about sleep and cooking and all kinds of great ideas of what to do. We haven't fully proven each one of them, and that's one of the challenges.
Yeah. So it's evidence-based medicine needs also to be applied to these things. It's not just entrepreneurial Silicon Valley types who are coming up with new models and saying, hey, it's not the trial and error that we're used to in Silicon Valley. It needs to be right. Supported by rigorous clinical practices is what I think what I hear you saying. Is that right? That's
exactly what I'm saying. And without that, it's frankly destined to fail, because you're going to end up spending if you look at your expenses, they're just going to be through the roof. These may not be physicians, but they're not cheap. And, to have them do a bunch of things that ultimately don't decrease the cost of the spend, is really challenging financially.
Yeah, and I agree with you. And both of these programs are actually under the guidance. You talked about Dr. Atul Gawande, and I forget the gentleman's name, but there's a physician from Stanford who's heading up the Apple model as well. So, I mean, these are trusted physicians, and I'm sure their background is such. So, I'm optimistic. I know that you're optimistic, and others are optimistic to see. Let's try some new things. Let's see, if we can't move the needle forward and make things better. So I'm going to transition to the soundbite section. We're going to talk a little bit about analytics. During this section, I just toss out questions, 1 to 3 minute answers, which is in some of the topics we're going to be talking about. It might be hard. It's more of a guideline than a rule. If you feel like you're not done, just keep going. I'm not going to cut you off. So I'm pulling this information primarily from a healthsystemcio.com article that you wrote, The Human Element of Health IT, which is a great article. And we're gonna really focus on data going around this. So you guys at your health system, you started a data-driven strategy, but it hit a roadblock. Can you sort of set this up for us? Give us a little background on the data-driven strategy and the roadblock that you had.
Yeah, we, when we went live with our enterprise EHR, we followed all the recommendations that we were told. We built a small reporting team with a supervisor, and we pushed forward and launched, and we expected magic to happen. We really expected to be able to push some buttons and get information out in a way that was really actionable and operational. And what we found, about a year after we went live, the honeymoon period was over. The folks who had been expecting and waiting for great information to make better decisions recognized that nothing was changing, and they weren't really getting what they needed. And when they asked for it, the time it took to actually get what they asked for was ridiculous. Right. And so it started a conversation within the organization at the highest levels. Finally, our chief strategy officer, our chief financial officer, and our CIO, Mark Hetz, got together, and they talked through what this might look like, and eventually asked me to look into it. I pulled together a very small team, myself and our BI developer supervisor at the time. And we brainstormed quite a bit. And I'll tell you, when I first started to unpack this issue, I was a little bit cataplectic about it because it's so complex. There's so many layers to it. And everybody had a different opinion of, why it wasn't working. And so ultimately, we decided to go down 3 main roads to evaluate this. The first was to look internally and really understand the need and the ask. So we met with every C-suite and VP at our institution for a half an hour. And I did that by design, a half an hour, because I wanted it to be a short period of time where they knew they had 30 minutes to tell me what's on their plate and what they need, and they need to spit it out. So we took 29 pages of notes from that, compiled that into themes, and that was one piece of our evaluation. The second was we looked external at places we thought were doing this pretty good. My brother works at Intermountain Healthcare, got a few connections there, spent some time with them to understand their model, spent some time with some academic centers who have a lot more resources than a typical community medical system, spent time with 4 or 5 total, compiled a bunch of notes from that. And then lastly, we looked at industry best practice, and we didn't limit it to our industry. We looked at Lyft and a few other places and spent time actually talking to folks in other companies. Compiled all that information ultimately into what ended up being a ridiculously long report, although it had a pretty brief executive summary. And I ended up presenting that to our executive team at our quarterly meeting, basically for approval of the recommendations that were coming forth. So it was a sorry, go ahead.
So can you give us an idea of some of the recommendations that were made? I mean, so you do a complete analysis of analytics within your organization. You talk to the executives, you gather that information. Can you give us an idea of what the executive summary to that might be to the group?
Yeah. So part of it had to do with we were just understaffed, and I always hate the idea of adding staff if we don't have to. It's a big topic. But the truth of the matter is we didn't have the right number of staff to make this happen. But more importantly, we were missing key staff functions that weren't there. And part of the problem was a disconnect, frankly, between what the requester wanted to communicate and what the BI developer heard and then built. And so that the delta between that communication is really what led to a lot of inefficiencies in our system. So what we did was we took a look at that and we said, how can we best improve on that? And one of the positions that we added was this clinical data analyst, which is really somebody who can really understand well what's being asked. This particular hire, who's awesome, had a background as an ICU RN and then was an Epic analyst for several years, really understood things well, and then learned reporting. So he understood the clinical side. He had some operational background as well, and then now he understands the reporting side. So those conversations now are much cleaner, much clearer, much more defined out of the gate. So we understand the ask a lot better. So you're not pumping out 30 iterations of a report. The second big position that was kind of different was our principal trainer position, which was, this is a brand new position, not usually something you find in analytics. But what we recognized is that folks weren't able to really fully comprehend the information we were delivering to them. So the goal with this position was twofold. Number one is to really spend time with the folks who are requesting information and getting reports and dashboards, et cetera, so they really understand what's in front of them so they can take action on them. But the second piece, which is probably even more important, is we also recognize we couldn't continue to scale and just add positions. We had to add self-service as one of our strategy frameworks moving forward. And so this person would be in charge of teaching folks how to leverage self-service to meet part of their reporting needs. So that was a big piece of it. The other big piece was data governance, and we can talk more about that in a bit, but that whole data governance piece was huge. And when I built the initial presentation to the executive team, I actually didn't dive terribly deep on that topic. What I did was I focused on the why, and then what I wanted to do was spend dedicated time on data governance in a separate forum. And fortunately, it worked out that way.
Yeah, so I do want to talk about governance. I also want to talk about scale and a little bit more about the roles. So let's go to governance. So, you emphasize the human element of, as the title of your article indicated, the first group that you really focused in on was the clinicians. How do ideas for talk to us about the process? So somebody has an idea for a new set of data they want to take a look at and some new information that would really help a process. How does it go from concept to development to operationalizing it and maintaining it? Give us an idea of the life cycle of that whole process.
Well, I should start by saying that we're fractionally through our execution of putting this in place. So we're not fully there yet, but as it stands right now, we spent a lot of time focusing on accountability and trying to make sure that throughout the organization, we have the structure in place so that when we have a request, that all the pieces are lined up, ready to go. Right. And that starts out by, we have our almost our entire C-suite is our steering committee, and they meet on a quarterly basis to set strategy around data governance. Below them, we have our data governors. And these are usually VP level and director level folks who have a specific domain that corresponds to their area. And then below them, we have the individual data stewards who do the actual work of understanding workflow and solving the data governance problems. And then below that, supporting all that, we have our Office of Data Governance. But we've built in the process where we can so far. So for example, we have a PMO now. And in our PMO project request process, data governance is one of the key line items there. So we have to get data governance to sign on and to sign off of projects. We've also incorporated data governance into ServiceNow. I'm not sure if you guys use ServiceNow when you're at St. Joseph's, but ServiceNow is basically a way to track the work that we do. And having that built in on those levels allows us to be able to get folks to utilize those tools, and then as a flow of that, it comes into the workflow for data governance. So for example, let's say you're using a report and you identify there's a data quality issue. You look at it and you're like, oh, these numbers are way out. This can't be right. Or you're looking at something even better and this thing says length of stay. How are they defining length of stay? Right. What does that look like? They can actually log a ticket in ServiceNow. That day it pops into our queue within the data governance queue, and then it gets worked by the appropriate data steward that corresponds to that domain, if that makes sense.
Yeah. Did you have a big cleanup project? I know that when we did our EHR implementation, I remember the day when somebody came to me and said, "Look, we have 5,000 reports in Orange County that we need to reconcile and whatever." And I'm like, 5,000 reports. I'm like, well, let's start with the basics. Like, when's the last time they've been accessed? And a good couple thousand of them haven't been accessed in years. Did you have that same kind of experience in cleanup?
We did. We did that type of cleanup, both for traditional SQL-based reports as well as for our dashboards and our reporting workbench reports as well.
How do you scale this? So you have a clinical data analyst and you have a new training principal trainer for analytics. Mm-hmm. That sounds like two people to me. So it would seem to me that they would either be extremely busy or that they figured out a way to scale the work that they're doing across the organization. Is there a trick, or is there something about scaling that you guys have figured out?
Well, we also added a few BI developers, traditional BI developers, to that mix, one of which we have dedicated to registries, which might sound a little odd, but with the work that's happening now around our ACO model and our basically our ambulatory contracts that we have, having somebody dedicated to registries is key, because most of this stuff feeds off of registries. So getting those right people in the right positions was important, but the single biggest improvement in our ability to deliver has been our work around lean and agile. So about 2 years ago, we started going down that road. My manager, Michael Olson, has really been at the tip of the spear on this, and we've completely revamped our approach based on agile and lean methodology with 3-week sprints.
Wow, that's well, I love it when we close out a show by introducing a topic that we could do a whole show on. So we'll definitely have to have you back and talk more about that, because that sounds like a lot of people talk about lean and a lot of people talk about agile, and I think they're, at least agile from where I sit, is one of the least understood terms within IT organizations, and it gets kind of convoluted. So Lee, I want to thank you for coming on the show. What's the best way for people to follow you?
So they can follow me on Twitter. It's Lee_MD_IT. I'm not sure that's the best name, but that's the one I got going right now. And then, of course, I'm on LinkedIn. And they can always email me with any questions they have. I'm at leemilligan@me.com.
Wow, sharing your email address. That's bold. I appreciate that. Also, you can follow me on Twitter at @ThePatientCIO, my writing on the Health Lyrics website. You can follow the show at This Week in HIT and check out our new website. Actually, it's not new. I have to change this. You can check out our website, thisweekinhealthit.com. Catch all the videos on the YouTube channel. I think we're now up to like 250 videos, and we'll produce another 5 or 6 from this show and put them out there for social media. So please come back every Friday for more news, information, and commentary from industry influencers. That's all for now.